Probando, probando, probando. Probando.
Bueno, buenos días. Simplemente indicaros que la sesión va a ser en inglés. Yo voy a decir estas palabras en español para daros la bienvenida y agradecer la reunión que tradicionalmente tenemos con la Sociedad Europea de Cardiología y el hecho de que pues, su presidente electo esté aquí con nosotros compartiendo esta mesa y que el doctor Kirchhoff nos acompañe para discutir las guías, una de las guías, en este caso la desfibrilación auricular. Luego, como sabéis, participan personas de la Sociedad Española de Cardiología que están en los cuerpos, por así decirlo, los bodies de la Sociedad Europea de Cardiología. Tenemos al doctor Zamorano y al doctor Héctor Bueno. Entonces, simplemente pues dar la bienvenida, decir que para la Sociedad Española de Cardiología pues es un placer tener esta sesión. porque uno de los aspectos fundamentales de esta reunión es el componente de formación y de práctica clínica, y desde luego las guías de práctica clínica son un elemento fundamental para ello, ¿no? Entonces, el comentarlas, el que tengamos la oportunidad de discutirlas, pues yo creo que es esencial. And now I would ask Dr. Héctor Bueno to go ahead with the rest of the meeting in English. We keep talking in English, okay?
So the first guideline that we will be presented is atrial fibrillation, and Professor Paulus Kirchhoff, who is the co-chair of these guidelines, will be introducing these guidelines to us. Paulus.
Buenos días. Good afternoon, everybody. Oops. Exit there. Yo no hablo español bueno, pero si tienen preguntas en español, pueden preguntar en español. I will answer in English, because my Spanish is not sufficient to tell you. I have the distinct pleasure to be here. Thank you for inviting me to Zaragoza. I'm impressed by this business park, and I was impressed by the posters down there. I've already learned something. But I'm mainly here to present to you the 2016 atrial fibrillation guidelines of the ESC. Why is atrial fibrillation important? Well, about 2 to 3% of the European population suffer from atrial fibrillation. And if you assume that the people in this room are on average 40 years old, 1 in 4 of us will develop AF. AF already causes between 1 and 3% of the total healthcare expenditure in Europe, and that's going to rise. So societies are spending a lot of money on AF because it causes premature death, strokes, hospitalizations, heart failure, loss of autonomy, and as we get older, that is becoming more and more important. And you've heard in the morning session possibly that it may contribute to dementia as well. The ESC guidelines were written by 17 people, including cardiac surgeons, a stroke neurologist, a specialist nurse. They were then reviewed by 33 specialist reviewers nominated by the ESC, by the EACTS, and by the European Stroke Organization, and by 49 reviewers nominated by 49 of the ESC member societies. And we had to go through several thousand comments of those to make sure that we don't say anything wrong. All recommendations that you find in the guidelines went through a structured process whereby we had weekly phone conferences discussing the recommendations, and then did a secret vote on them, and only recommendations that were supported by at least 75% of the task force members made it into the guidelines. The ESC also gave us the opportunity to commission 3 external systematic reviews that informed some of our recommendations. In the end, we came up with 154 recommendations, of which 2/3 are supported by good evidence, level of evidence A or B, and 1/3 are the eminence-based recommendations where expert consensus has to fill the gaps of evidence. Atrial fibrillation is often underdiagnosed, and we have therefore a list of recommendations how to screen for atrial fibrillation so that you can start treatment before the first stroke occurs. And that should be done in everyone who sees a doctor and who is older than 65 years old. Should be done with prolonged ECG monitoring in survivors of a stroke or a TIA. And you should also use pacemakers and devices to look for atrial high rate episodes. There is also a reason to consider even longer ECG monitoring in patients with, for example, cryptogenic strokes or embolic strokes of unknown source. I want to briefly comment on pacemakers. I've actually seen 2 posters down there that said we have detected atrial fibrillation on pacemakers. You can detect atrial high rate episodes on pacemakers, and they are relevant, but they are not the same as atrial fibrillation. And therefore, in the guidelines, we recommend that you monitor for such episodes, but that you only start treatment after you have documented atrial fibrillation by a conventional Holter ECG, because we don't really know whether, for example, anticoagulation is indicated in all patients with atrial high rate episodes. Once you've diagnosed atrial fibrillation, and this is probably the central illustration of the entire guideline, you and your team should make sure that every patient is treated with an integrated care approach. That doesn't mean that 20 people have to treat each patient, but every patient should receive treatment for the acute condition, acute hemodynamic stabilization. Every patient should be assessed for underlying cardiovascular conditions, and these should be treated. Every patient should be assessed for stroke risk, and then anticoagulation initiated where necessary. And these three treatment domains have a prognostic impact. They can prolong life, they can prevent strokes. We have good evidence that they do this. All patients also should be treated with rate control if they have fast conducting AF, and patients who are still symptomatic after being treated with these four domains should be offered rhythm control therapy. In these treatment options, we don't really know whether they have a prognostic impact, and in rhythm control therapy, we only have a good justification to use it when patients are symptomatic. There are quite a few recommendations on how to treat underlying cardiovascular conditions. I just want to highlight two. One is the detection of mitral valve disease. And there are two recommendations, both 2AC, so it's more expert consensus than evidence, that if you have a patient with mitral regurgitation that is amenable to mitral valve repair, and that patient develops atrial fibrillation, that should probably be one of the factors to consider surgical repair of that mitral valve. Or, less common in Europe, more common in India, if you have a patient with mitral valve stenosis who develops atrial fibrillation, that is usually, and by the way, these patients often become symptomatic when they develop AF, that is a reason to consider mitral valvulotomy in patients, again, who have a suitable anatomy for that. Another, probably more common problem in Europe that I would like to highlight is we have good data now that obesity promotes AF. Even to the extent that if you reduce weight aggressively in patients scheduled for AF ablation, you can actually avoid the procedure in some of them if they manage to lose weight. And that should clearly be a part of integrated AF management in obese AF patients. There are several other conditions that are described in the guidelines. I will not go through that for the sake of time. Oral anticoagulation is probably the best studied component or domain of atrial fibrillation management. And I would like to spend 1 minute to go back where we come from. This is a TOE picture of a patient who actually did not have a left atrial thrombus. You can see the thrombus here in the left atrial appendage. And this same patient had a TOE 4 days before in sinus rhythm and didn't have a thrombus. So this is one of the few examples where you can really see a thrombus forming. Oops. Sorry, there's something wrong there. Can you help me with the presentation? Thank you. The observation that, oh yeah, let me just go through that such thrombi can form has then led to the concept that anticoagulation can prevent these strokes. And the first use of anticoagulation was in the 1980s. We used warfarin. Warfarin was discovered in the 1930s. There was an epidemic in some areas in the USA where cattle died in large numbers because of internal hemorrhage. And they were fed mouldy clover. And researchers then isolated decumarole from that clover as the active substance that caused the bleeding. And the Wisconsin Association of Research Fellows then developed warfarin as a substance that would cause that type of bleeding. And it was used since 1948 as rat poison. Rats, as you know, are very smart animals, and if they eat a poison and they see a fellow rat eat that poison and die, they will not eat it. But if that rat eats a poison and then dies 2 days later because of internal hemorrhage, the rat cannot make that connection, so it works as rat poison. 6 years later, an American former soldier tried to kill himself by eating rat poison. He was admitted to hospital, had an INR of above 8. Well, we didn't call it INR then, but he survived. And that single human experiment was the main trigger for the FDA to then approve warfarin as an anticoagulant. We have gone beyond that, obviously, but this is how warfarin was approved 60 years ago. It has been then tested in the 1980s as a stroke prevention therapy in AF, and it's highly effective when it is used at the right dose. We now know that we have other substances, non-vitamin K antagonists or anticoagulants, that work as fixed-dose treatments that have the same stroke prevention effect, and importantly, they are safer. As you can see from this meta-analysis, they only cause, they lead to 10% fewer deaths compared to warfarin in the phase 3 trials, and that is probably mainly driven by 50% less intracranial hemorrhages. The same can be found in real-life data. This is a large data set with patients in the US treated with the Bigatron, which was the first such anticoagulant. Therefore, the guidelines recommend anticoagulation in all AF patients at risk of stroke. That is, patients with at least 2 of the Chas-Vasc factors, and you don't have to look that hard for female gender in those 2. Those with 1 Chas-Vasc factor should be considered for anticoagulation, and those without any of the Chas-Vasc factors do not need any antithrombotic therapy. They are at very low stroke risk. In patients who are eligible for anticoagulation, a NOAC should be preferred because it is safer than vitamin K antagonists, but vitamin K antagonists remain valid alternatives for those patients in whom NOACs cannot be used and or where NOACs are not available. The guidelines have a big emphasis on what is called AF heart teams. And in patients who cannot be treated with a conventional anticoagulant, such a heart team should probably discuss what to do, whether to use another anticoagulant or whether to consider, for example, left atrial appendage occluders, a technology where we have less data, but that is there and available. Patients on anticoagulants have a risk of bleeding. About 2% of patients who are treated with anticoagulants have a major bleed per year. That is much less bleeding than the stroke risk without anticoagulation, but still a concern. We have means to reduce bleeding risk, and that is to tackle modifiable bleeding risk factors. And these are the 4 bleeding risk factors that are known: hypertension, especially uncontrolled blood pressure, a labile INR in patients on vitamin K antagonists, medication predisposing to bleeding, especially antiplatelet agents and non-steroidal anti-inflammatory agents, and an excess of alcohol. All of these are modifiable, at least to some extent, and if we are concerned about bleeding, and we all should be, we should try to reduce modifiable bleeding risk factors. The fear of bleeding should not lead to withholding anticoagulation. That is one of the most common errors that is observed in surveys of atrial fibrillation patients, that physicians do not give anticoagulants because of a fear of bleeding. That is almost inevitably not the best choice. If you have a patient with a bleed, the most important thing is that you should agree what to do before that happens, because this is always an acute event. It will happen Saturday night. It will happen in a situation where the most senior physician there is someone who doesn't know that much about anticoagulation, so it's important to establish an institutional protocol. Most bleeds can be managed with a short pause of the anticoagulant and with local measures, including, if it is more severe, treatment of the cause of the bleeding. For example, a gastroscopy or a surgical treatment if it was a trauma. Only in severe life-threatening bleeds is a administration of either coagulation factors or a reversal of the non-vitamin K antagonist oral anticoagulants indicated. There are some relatively good observational data that show that the mere stopping of the NOAC actually leads to faster hemostasis and better survival in patients with life-threatening bleeding than the reversal of vitamin K antagonists, and that is probably just due to the longer half-life of the vitamin K antagonists. Rate-controlled therapy, as I said, we don't have much data, but should be offered to all patients whose heart rate is too high. Probably a reduction of the ventricular rate below 110 beats per minute is sufficient. We have 3 different types of agents. We have calcium channel antagonists, diltiazem and verapamil. We have beta blockers and digoxin. All of these can be used in patients with preserved ejection fraction, and in patients with reduced ejection fraction, you should not use the calcium channel inhibitors because they can have a negative inotropic effect. The prognostic effects of beta blockers and digoxin in patients with heart failure and AF are the same. They are neutral. Rhythm control therapy has changed to some extent, but the main indications have remained the same. Rhythm control therapy is only indicated at present to improve AF-related symptoms in patients who are still symptomatic after rate-controlled therapy. And we recommend to use the ERA score to measure symptoms so that you can actually document how symptomatic the patient was and then see whether things improve on rhythm-controlled therapy. And this is the ERA symptom scale, has been used for a few years. There is a new split between class 2A and class 2B now because there are some data to suggest that patients who are in class 2B, which is a bit more severe than class 2A, have a greater benefit from rhythm-controlled therapy than those who only have mild symptoms. Anti-arrhythmic drugs have been around for over 200 years. In 1749, that's probably the first description of quinine, the bark of a tree that was the biological substance from which quinidine was isolated, helps to prevent AF in patients with rheumatic heart disease. This has then led to chemical creations of other sodium channel blockers in the 1950s and 1960s. And the development has gone on. We currently have 5 anti-arrhythmic drugs: amiodarone, dronedarone, flecainide, propafenone, and sotalol. There are a few others that are either only available IV or not available throughout Europe. They are discussed but not mentioned in detail in the flowcharts. They are very useful, but they don't come without a risk, and therefore it's important to pick the right patient for each anti-arrhythmic drug. In the last 20 years, we have seen the development of catheter ablation. The initial attempts of catheter ablation of AF were linear lesions and they were futile. And in 1998, the group in Bordeaux has identified that foci in the pulmonary veins can trigger AF, and then the isolation of the pulmonary veins with radio frequency catheter ablation, as shown here, has developed into a standard intervention to prevent AF. And you can see on the right that this is now also done with cryoballoons, and at least in one large trial they are as effective and as safe as radio frequency energy. All other ablations beyond pulmonary vein isolation have much less evidence when it comes to prevention of recurrent AF. One thing that you will not find in the rhythm control flowcharts of the new guidelines is a distinction between persistent and paroxysmal AF. And the reason for that is that the main differences between anti-arrhythmic drugs and cardioversion on one hand and catheter ablation on the other hand are the same for paroxysmal and persistent AF. This is a meta-analysis that we commissioned for the guidelines, and it shows that catheter ablation in persistent AF is more effective in maintaining sinus rhythm than anti-arrhythmic drugs plus cardioversion, similar to paroxysmal AF. Again, not without complications. Catheter ablation has a complication rate of about 5%, and that is not negligible, but the complication rate is not that different from anti-arrhythmic drugs either. And that leads to this flowchart on how to decide on rhythm control therapy. The entry into that flowchart is a patient who has symptoms related to AF despite rate control therapy and despite treatment of all the other domains, and who wants further rhythm control therapy to improve symptoms. And then you have a choice of 4 anti-arrhythmic drugs or catheter ablation in patients without structural heart disease. You have a choice of dronedarone, sotalol, or amiodarone in patients with coronary artery disease, significant valvular heart disease, or abnormal left ventricular hypertrophy. And in patients with heart failure and reduced ejection fraction, you are left with amiodarone as the only anti-arrhythmic drug due to safety concerns. In all instances, you can offer catheter ablation, but the evidence for that is weaker. The efficacy is a bit bigger, and of course you have more complications in the very short term, because most of the complications of AF ablation occur directly after or during the ablation procedures, whilst the complications of anti-arrhythmic drug therapy can add up over time during long-term treatment. In patients who have failed an anti-arrhythmic drug therapy or a first catheter ablation and who are still in need of rhythm control therapy, i.e. who are still symptomatic after that, you have a choice of either adding catheter ablation to an anti-arrhythmic drug, repeating catheter ablation, which seems to be especially sensible when the pulmonary veins have not been fully isolated in the first instance, or choosing another anti-arrhythmic drug, which will then often be amiodarone, which is more effective than the other anti-arrhythmic drugs, but also has more, especially extracardiac side effects. And if you go through a second failure, that's probably the place where you should talk to people who know more than I or you do, and that's probably a team of people. That's what I would like to call an AF heart team. The ERA has actually done a survey, and 80% of EP doctors in Europe believe that one should have AF heart teams, but less than half of them have access to AF heart teams. So there is something to do there. And these heart teams can then propose whether to use a third anti-arrhythmic drug, a different ablation strategy, and or surgery for AF, which is, there is much less data than for catheter ablation, but the few data that we have suggests that it is more effective in experienced hands than AF ablation per se. If you don't want to remember all the 154 recommendations, you can download the pocket guidelines from the ESC, and in the AF pocket guidelines you find an overall treatment manager that has been developed together with an EU-funded research project that gives you sort of an overall approach to AF management in your patients. You're basically asked a set of questions, and then an algorithm proposes to you a potential treatment. And with that, I would like to thank you for your attention. I'll remain open for questions.
Sorry, we don't have enough time to have any question now, so let's move on to the next presentation by Dr. Zamorano. And he's going to talk about the guidelines about cardiovascular disease prevention. Go ahead.
Gracias, Luis, queridos amigos. Para mí es un placer estar aquí con vosotros y contaros un poco un resumen y que creo yo que es lo más importante de las guías de prevención cardiovascular del 2016. Primero, el contenido de la guía es muy extenso. Hablamos desde lo que es el riesgo, la estimación del riesgo, quién tenemos que hacer y sobre todo, y es en lo que voy a haceros más hincapié, en los objetivos que tenéis que tener en vuestros pacientes. Lo primero que tenemos que saber es que la prevención es una palabra formidable, se nos llena la boca al decirla, pero es que realmente ahorra mucho dinero. O sea, realmente ahorra mucho dinero en cardiología. Y he querido poneros esta diapositiva para deciros que realmente donde ahorra dinero la prevención es en las enfermedades cardiovasculares. Fijaros, al comparar la reducción de dinero que podemos hacer de ahorro en la prevención de la enfermedad cardiovascular frente a la oncología. ¿En quién tenemos que estimar el riesgo cardiovascular? Tenemos que saber que todos los pacientes tienen riesgo cardiovascular aumentado, si tiene historia cardiovascular precoz en la familia, si tiene hipercolesterolemia familiar, si tiene un factor de riesgo único aumentado pero muy elevado, o algunos pacientes que per se, como son los diabéticos, tienen un riesgo también aumentado. ¿En quién deberíamos hacer una estimación del riesgo? Vosotros estáis en la consulta, ¿en quién? En todos los varones de mayores de 40 años y en todas las mujeres mayores de 50 años o posmenopáusicas. Bien es verdad, y ya sabemos, que la edad penaliza o favorece. Una persona mayor per se va a tener mayor riesgo y una persona joven va a tener menos riesgo. Lo que sí que tenemos que utilizar, según la guía europea, es nuestro proyecto SCORE de la European Society of Cardiology, en el cual estamos considerando la edad, la presión sistólica, el sexo, el colesterol total y el tabaquismo. Estos son los factores que vamos a poder utilizar en el SCORE para calcular el riesgo. Claro, aquí tenemos que saber que si estamos hablando con una mujer de 40 años que fuma 3 paquetes al día, que tiene 200 milímetros de mercurio de presión sistólica y 300 miligramos por decilitro de colesterol, el riesgo de SCORE es 0. Y es 0 porque la mujer esta no se va a morir a los 40 años, no se va a morir a los 50, se va a morir a los 51. Entonces aquí, como estoy estimando un riesgo de 10 años, va a salir muy bajo. Por eso tenemos que utilizar las tablas de riesgo relativo que aparecen en la guía para comparar mi riesgo relativo con un paciente de igual edad y diferentes características. Pero la Sociedad Europea sigue empleando el SCORE. Hay otras en Europa, como las guías británicas, que hacen el Long Lifetime Risk, pero en la europea seguimos recomendando el SCORE. Lo que sí sabemos es que aquellos pacientes con enfermedad cardiovascular documentada, diabéticos con lesión de órgano diana o con un factor de riesgo mayor asociado muy elevado, o aquellos pacientes con enfermedad renal crónica estadio 4, estos categorizan inmediatamente a muy alto riesgo. Y estos son, si os dais cuenta, los que vemos habitualmente en cardiología. Otros marcadores genéticos, historia familiar, factores psicosociales también son importantes a considerar. Biomarcadores. No se recomiendan en la guía la determinación de biomarcadores de forma estándar en el screening de nuestros pacientes. Y esto es una cosa que tenemos que saberlo. Y tampoco se recomienda el uso de test genéticos en screening poblacional. Tampoco se recomienda, yo creo que es muy importante saber qué se recomienda y sobre todo qué no se recomienda, hacer un ecocarotidio a nivel screening poblacional. Indicación 3. El grosor íntima medio no está recomendado. Sí, el score de calcio con el TAC está en 2B, pero teniendo el valor que podemos darle a este score de calcio. ¿Cuáles son otros marcadores? Bueno, la enfermedad renal crónica, ya os lo he dicho, estadio 4, muy alto riesgo importante. Lo que está claro es que la infección por influenza hace un riesgo de infarto que multiplica por 4 durante las infecciones. Esto lo sabemos, la periodontitis, el síndrome de apnea del sueño también. El cáncer, y este año ha salido una nueva guía de cardio-oncology, pero también en pacientes que han tenido cardiotóxicos en tratamiento de antraciclinas, sabemos que pueden producir en el largo plazo una cardiotoxicidad. Y ahora los pacientes, gracias a Dios, ya no se mueren de cáncer, pero van a acabar en cardiología años después. Un paciente que hemos tratado de un cáncer de mama con antraciclinas, podemos a los 5 años darle de alta de oncología y desarrollar insuficiencia cardíaca a los 10 años. Con lo cual es muy importante tener esta nueva consideración en cardiología. Las enfermedades autoinmunes aumentan el riesgo cardiovascular 1.5 veces en la artritis reumatoide. La disfunción eréctil, ya sabéis que comparte los factores de riesgo y precede habitualmente a la enfermedad cardiovascular en unos 3 años. ¿Qué sabemos de otros grupos de riesgo? Bueno, en principio, los pacientes, hay que hablar de edad de riesgo más que de edad del carnet de identidad. Así que aquellos pacientes que tienen una historia familiar de dislipemia familiar, se recomienda actuar desde el principio con ellos y establecer el diagnóstico o excluirlo. La edad también se considera de una forma importante en la guía. ¿Por qué? Porque hace que determinados puntos de corte somos, por ejemplo, más permisivos con cifras de presión arterial, y en aquellos pacientes de edad avanzada la cifra de presión arterial sistólica podríamos considerarla adecuada entre 140 y 150 milímetros de mercurio. También hay que decir que hay cierta controversia en el tratamiento con estatinas en los pacientes muy mayores por encima de 80 años y también, luego hablaré de ello, se relaja un poco la cifra de control glucémico. En las embarazadas, la preeclampsia triplica el riesgo de padecer hipertensión. El 50% de las mujeres que desarrollan diabetes gestacional tendrán diabetes en un plazo de 5 años y hay que hacer prevención en este grupo de pacientes. Básicamente, los niveles de presión arterial se mantienen con la salvedad que he dicho, 140-90 milímetros de mercurio, luego hablaré un poquito de ello. Los niveles de lípidos sí cambian, en alto riesgo menos de 70, y esto es lo importante, o reducción del 50% si mi LDL basal está entre 70 y 135. También hablaré de ello. Y diabetes, una glicada menor de 7, con algunas matizaciones que luego veremos. Lo que sí está claro es que esto no es cosa de médicos, es cosa de médicos, de enfermos, de familias y de la administración, y todos tenemos que actuar de forma conjunta para la prevención cardiovascular. Ejercicio sí, pero ¿qué quiere decir ejercicio sí? Bueno, sabemos que tiene un efecto positivo, yo creo que es la mejor polipil que hay, no hay ninguna duda, sube HDL, baja LDL, controla la tensión, pero ¿qué quiere decir ejercicio sí? 150 minutos a la semana de actividad física moderada o 75 minutos de actividad física intensa, con un incremento gradual hasta 300 minutos semana o 150 minutos semana de actividad intensa. ¿Aeróbico o anaeróbico? Bueno, aeróbico 3-5 sesiones a la semana, preferiblemente diario. Ese es el ejercicio que tenemos que recomendar. Anaeróbico, menos 2 días a la semana, 2-3 sets de 8 repeticiones, 8-10 repeticiones cambiando intensidad. Enfaticemos el ejercicio aeróbico. Del tabaco ni hablamos. Lo que está claro es que el tabaco tenemos que abandonarlo de forma proactiva. Es decir, nosotros tenemos que insistir en abandonar el tabaco del paciente, pero no es una cosa solo del paciente, es una cosa de los dos. Nutrición. ¿Qué tenemos que hacer en nutrición? Dieta mediterránea. ¿Qué es esto de la dieta mediterránea? ¿Qué es lo de la dieta mediterránea? Básicamente lo que se recomienda es menos 5 gramos de sal al día, 2-3 piezas de fruta al día, esto es más de 200 gramos de fruta, 2-3 vegetales al día, más de 200 gramos, y 1 o 2 veces ingerir pescado a la semana. Cintura. También hablamos, he oído muchas veces, bueno, ¿y cuánto tenemos que tener el perímetro abdominal? Bueno, lo que tenemos que hacer es, si la mujer tiene un perímetro abdominal de más de 80 centímetros en su máxima extensión, hay que desaconsejar que gane peso. Y si tiene más de 88, que pierda peso. En el varón es 94 y 102 para que no gane o que pierda peso. Colesterol. El target es el LDL, pero también podemos hablar en algunas poblaciones especiales, como por ejemplo los que tengan triglicéridos muy elevados, del non-HDL colesterol, es decir, el colesterol total menos el HDL. Y aquí esta tiene la ventaja de que no precisa ayuno, no está interferido por los triglicéridos, y en este subgrupo de pacientes pues probablemente tengamos que hacerle más caso aquí. Como decía, muy importante, y esto es un cambio en las guías, reducción del 50% en los de muy alto riesgo, si LDL entre 70 y 135, o entre 100 y 200, reducción del 50% en los de alto riesgo. ¿Cómo? Con estatinas. Primer escalón, estatinas. Esto es lo que tenemos que hacer. Estatinas a dosis altas. Y si no logro el objetivo, tratamiento combinado. Pero estatina es lo primero que tenemos que hacer. En la diabetes, ¿qué hacemos? Metformina, clase 1. ¿Y qué pasa en los pacientes diabéticos tipo 2 y enfermedad cardiovascular establecida? En estos, DOSA, debe considerarse el uso de inhibidores de SGLT2. La presión arterial, antes decíamos, medidas higiénico-dietéticas, lo importante es bajar la presión más que el fármaco, eso lo individualizaremos de acuerdo a la patología concomitante, clasificamos como siempre, esto no ha habido ningún cambio, hay unas guías nuevas que van a aparecer específicas de hipertensión arterial, no hay ningún problema en este sentido, hipertensión normal alta, aquí tenéis la definición, hipertensión grado 1, grado 2, grado 3, o hipertensión sistólica aislada. Claro, me diréis, bueno, ¿cuál es el objetivo terapéutico en la hipertensión? Pues mirad, esto también tiene algunas matizaciones. La presión debe ser menos de 14,9 en los pacientes menores de 60 años, objetivo como lo teníamos. Si yo tengo una edad mayor de 60 años y mi presión es más de 160 milímetros de mercurio, el objetivo ahí puede ser un poquito más laxo. Y mi objetivo tensional es entre 140 y 150 milímetros de mercurio. Ahora tengo un paciente menor de 80 años, esto ya es una indicación, mayor de 80 años, perdón, es una indicación también clase 1, que es no frágil y que tengo una presión de 160, pues aquí, de nuevo, mi objetivo sistólico, en este caso, 140-150. Como veis, un poquito más laxo en los pacientes de mayor edad y en esto, pues hombre, ha influido el reappraisal, como todos sabéis. En el fondo, ¿cuándo tenemos que hacer? Tenemos que hacer siempre. Esto es una cosa no solo del enfermo, a veces la prevención la tomamos como que sea una cosa del enfermo, pues sí, hay que prevenir antes que curar, pero esto tiene que ser un hecho proactivo por parte nuestra y tenemos que hacer programas especializados de rehabilitación controlados por los cardiólogos, tenemos que hacer programas en las consultas externas y en los hospitales. La guía acaba con una cosa nueva que es común a todas las guías, que yo creo que es muy interesante recordar, que son el to do and to do not. ¿Qué tenemos que hacer y qué no tenemos que hacer? Hacer estimación del riesgo cardiovascular, clave. ¿Por qué? ¿Por qué hay que estimarlo con una tabla? Pues porque el riesgo percibido está publicado, lo que yo percibo como médico cuando entra un paciente en la consulta es un riesgo menor que el que sale en la tabla. Luego hay que hacer la tabla. La guía nos recomienda el score. Yo estoy para hablar de las guías, pero si decís, ¿y yo qué recomiendo? Yo recomiendo que utilizáis la que tengáis. Si utilizáis el REICOR, fenomenal. Si utilizáis el SCORE, fenomenal. Pero desde luego no recomiendo que no utilicéis ninguna. ¿Qué no hacer? No es útil estimar sistemáticamente HDL, test genéticos, biomarcadores como screening poblacional. No hay que hacerlo. ¿Qué tenemos que hacer? Hay que ver los factores de riesgo asociados en un paciente para identificar los de muy alto riesgo. La enfermedad renal crónica severa, la enfermedad cardiovascular. Tenemos que saber otras condiciones que aumentan el riesgo, periodontitis, apnea del sueño, disfunción eréctil. No tenemos que hacer ecocarotidio sistemático, a todo, como screening poblacional. No tenemos que hacer el análisis de la onda de pulso, como sistemático poblacional. No hay que hacer esto. Se recomienda que tengamos una aproximación multidisciplinar para la prevención. En el fondo, es decir, esto no es cosa del paciente, es cosa de todos. No tenemos que ignorar la peculiaridad de cada paciente. Si es muy mayor, tengo otros objetivos terapéuticos en algunas cosas, como en la tensión, las mujeres, las minorías étnicas. Tenemos que individualizar la prevención. No tenemos que olvidar que el objetivo lipídico es el LDL. Y en este sentido, recordar que el LDL basal me marca mi objetivo terapéutico, porque esto es nuevo en estas guías y es consistente en las guías de lípidos. Luego tengo que saber de dónde parte el enfermo. No es muy alto riesgo menor de 70, no. Menor de 70 o el 50% sí o sí está entre 70 y 135. No tengo que tener un objetivo único de control de diabetes. ¿Qué quiere decir? Esto ha sido también un pequeño cambio. El objetivo global de menos de 7% de hemoglobina glicada está bien, pero en pacientes ancianos o frágiles puedo permitir menos de 7,5 o incluso menos que 8, o en jóvenes podemos decir más estricto, menos de 6,5. Tenemos que recomendar iniciar tratamiento para la hipertensión arterial pronto, si es una hipertensión muy severa, e incluso con tratamiento combinado. Y por último, no tenemos que desaprovechar ninguna oportunidad para hacer prevención cardiovascular. Esto no es solo cosa del hospital, es una cosa de primaria, de las autoridades, de la consulta externa y del hospital. Muchas gracias.
Thank you very much for this very elegant presentation. Pepe, due to the lack of time, we have to continue with the next one, but thank you again. And the next presentation will be given by Dr. Hector Bueno, and he will share with us heart failure. Hector, please.
Thank you, Joran. I will honor our guests and I will present my presentation in English. I don't have a historical approach to the guidelines as the beautiful presentation by Paulus, and I don't have nice pictures and slides. So my presentation will be much drier in terms of focusing the guidelines. It's a huge guideline. There's a lot of messages, so don't intend to learn what the guidelines come from my presentation. In fact, I will give you a 10,000 feet view of what it is in the guidelines and how you have to interpret some of the information, but of course you have to read the guidelines if you really want to understand that. These are my conflicts of interest. And so the first thing, of course, we know what's heart failure, which is syndrome. It's a syndrome characterized by symptoms, usually signs, and caused by structural and functional cardiac disease. That means that you have to do some clinical evaluation always in diagnosis. One of the first changes is that we have now a new classification in which the traditional HFrEF and HFpEF, and there in the middle there's heart failure with mid-range ejection fraction between 40 and 49% with some elevation of natriuretic peptides and structural heart disease. This is debatable, but the main reasons for this classification is to bring attention to this gray zone, whereas clear evidence are not, and to, let's say, try foster research in this particular gray zone. So the diagnosis of heart failure, as I mentioned, has three main steps. The first is assessment of the probability of heart failure. That comes through clinical history, physical examination, and ECG. If everything is normal, it's unlikely that the patient has actually real heart failure. Of course, the second step is if there's one positive, natriuretic peptides, and you have the thresholds there for diagnosis, which are different from acute and chronic setting. And if these are normal, again, it's unlikely that the patient has heart failure. And the third step would go for echocardiography. This is not routine in our setting, particularly in primary care. So that's something to think about in terms of practice. So there's a recommendation on how to use imaging. Of course, you cannot read it. I'm just going to say that you have the recommendation of echocardiography is one. The recommendation for cardiac magnetic resonance is also recommended when there is no clear view with echocardiography and you need to really untangle what is the mechanisms. And invasive coronary angiography and so on, it's recommended, but you have to read it. There's, of course, a critical point in terms of preventing or delaying heart failure, and for that, general recommendations for the treatment of hypertension, preventing progression of atherosclerosis, and smoking, quitting smoking, it's essential. The use of the treating all the risk factors, and for instance, using empagliflozin in diabetics, it's a role. And of course, on those already with left ventricular dysfunction or heart failure, use of ACE inhibitors and beta blockers is essential. The role of ICDs to prevent sudden death is also recommended for a number of patients. This is the algorithm, and this is new, of the medical, of the management of patients with heart failure. It's a bit complex, so I will stop here a little bit, and you will see that there's a number of either first steps and also a continuous evaluation of the roles of diuretics and ICD. There's some, like in some contracts, there's a small letter that you would have to see. This is not like contracts where there's a tricky part. It's just that they try to replicate the inclusion-exclusion criteria of randomized trials in which these A, B, C letters actually were for the prescriptions. They try to homogenize the recommendations, but that's a small letter for this algorithm. What is important first is that the first line therapies remain as it were. So the first-line therapies for all patients with symptomatic heart failure with reduced ejection fraction, are the ones that we've always been using. ACE inhibitors, beta blockers, and if needed, MRAs. So that remains as the first step for the management of heart ref. That has not been changed. If patients, and of course, diuretics should be used in patients who remain symptomatic and need some adjustment or have volume overload, and ICD also should be used in the patients with recommendation. There's been, of course, a new trial recently published which actually will make to rethink one of these recommendations, but this goes throughout the treatment or the management of patients with heart failure. When optimal medical therapy has been achieved and patients remain stable, there's the recommendation to consider 3 option therapies. That means that you can use one or the other or all together. So this is not competitive. It means that depending on clinical characteristics, you may want to go for ARNI, for sacubitril/valsartan, if they're tolerating ACE inhibitors. Whether they have a wide QRS, you may consider CRT, and the patients are still with a heart rate over 70, you may consider ivabradine. Green means 1 indication, orange means a 2A indication. The recommendation for sacubitril/valsartan is a 1B, very strong trial. Again, the recommendation is for those who remain symptomatic after optimal treatment with ACE inhibitors, beta blockers, and MRA. And these are the indications according to the randomized trial inclusion criteria. Ivabradine is also considered as a 2A indication for those with heart ref and remaining symptomatic and heart rate over 70. CRT, and I will get into the clear indications. Basically, heart ref with a wide QRS, you have this 1A or 1A indication. I won't get into the details, and is not indicated in patients with a narrow QRS. If you want to get into more debatable indications, you can go for it. I will not mention that. Finally, when you have used all these approaches for treatment, first-line treatment, optimal therapy achieved, and the second lines, and then you have 3 options. You can use 1, 2, or 3, depending on the clinical characteristics. Then you have some rescue therapies that you can use. In terms using of hydralazine is to survive. There, in general, evidence is lower, and using of digoxin and anti-PUFA it's indicated or may be considered. There's a number of drugs that are not recommended or should not be used in patients with heart failure, as thiazolidine and DIONS, NH and COX, EPS, diltiazem or verapamil, and the combination of ARBs and ACE inhibitors. Contrary-wise, in the patients with HFpEF, with preserved ejection fraction, only diuretics have an evidence to be treated. So you can see the real contrast between the amount or the number of treatments, the options that we have, as compared with this, in which only rule out comorbidities and not diuretics are recommended. Why? Because we have no evidence to recommend one or other treatments. Of course, you will have to treat comorbidities, you will have to treat blood pressure, high blood pressure, or other cardiovascular risk factors, but there's no evidence that actually changed the prognosis of these patients. There's a larger chapter for acute heart failure as compared with the 2012 guidelines. So the new chapter, of course, recommends of patients with suspected acute heart failure to rule out as soon as possible, even in the pre-hospital phase, cardiogenic shock. If that is, immediately start with circulatory support, pharmacological or mechanical, respiratory failure, and there is still oxygenation, non-invasive, if needed, mechanical ventilation, and then stabilize patients. If that is not the case, then this algorithm or this acronym of CHAMP that is ruling out some cardiovascular causes of acute heart failure, which account for coronary hypertension, arrhythmia, mechanical complications, and pulmonary embolism, should be ruled out as potential causes of acute heart failure, decompensation or initiation, and then start specific treatment according to the specific guidelines. If not, the general management should be done. The assessment of acute heart failure is recommended on the traditional NORIA algorithm and using congestion and hypoperfusion, getting from warm, dry patients to cold, wet patients. This would be mostly patients in cardiogenic shock or very sick patients. There's a gradient in severity. The management is recommended to follow this classification, and you get these 4 groups of patients. And in terms of wet and warm, which are quite frequent, you will have the vascular type, usually hypertension predominating the presentation, and the cardiac type in which congestion and edema is more frequent. However, you have specific recommendations for these phenotypes, but you will see that the changes in vasodilator or diuretics or vasodilators, diuretics, really no big change in terms of management. Of course, sick patients will need inotropic therapies and some additional support. So as you can see, again, the only one indication for acute heart failure is diuretics. There's no evidence still, after so many years, of any other treatment really changing prognosis in these patients. You have some recommendations on how to use these vasodilators, basically nitrates in patients who are not hypotensive, still are a 2A indication. Of course, for sicker patients, you may consider inotropic agents, but it's still 2B, should not be used, of course, in those who do not show hypoperfusion. Use of vasopressor are not recommended with a high evidence. You have to monitor, of course, blood pressure if you're using it. The only one indication is thromboprophylaxis. That's a real only one indication in addition to diuretics in these patients. What is important, and this is a strong indication in the management, is try to avoid stopping the use of beta blockers or evidence-based therapies or disease-modifying therapies in the acute phase, and if you have to try to restart as soon as possible. And those are very strong indications. So even in acute setting or acute decompensation, try not to stop if possible, and if you have to stop or is de novo, start treating this patient as soon as possible. In terms of cardiogenic shock, again, not too much recommended, too much evidence. In fact, the one indication is for monitoring in general management. In fact, when you go to therapies, inotropic agents 2B, vasopressors 2B, routine balloon pumping is 3 for MI patients. So still a lot of lack of evidence for the management of cardiogenic shock patients. When we have to go to the mechanical circulatory support or heart transplant, again, not too much evidence, but still there's recommendations of which patients actually are eligible for left ventricular assist device, also some indications for heart transplantation. And of course, there's a number of recommendations for the management of particular clinical cardiovascular situations. Of course, I will not get into the details, particularly atrial fibrillation, but you can see there's no strong evidence apart from anticoagulation. Rhythm control, you can see there's no strong evidence for treatments. Similar in fact, actually anticoagulation is the best established evidence, as we heard before, also in acute heart failure setting. Similar for ventricular arrhythmias, bradyarrhythmias, and I will not get into the details. I think an important part of the guidelines are devoted to comorbidities. Many, if not most, of our patients with heart failure are older patients. They have many, sometimes several comorbidities, and there's specific chapters to manage how to manage coronary artery angina, cachexia, iron deficiency, and anemia. Please go to the guidelines and check, because you will see that many of your patients will have one or several of these comorbidities. So this important is highlighted in the guidelines, and you want to maybe take a look at what are the specific recommendations for the management of comorbidities in patients with heart failure. Finally, again, you cannot read this, but I think there's a good recommendations in terms of patient education and professional behaviors to optimize the teaching and learning for shared decision makers, particularly before discharge, immediately after discharge. There's a good number of recommendations, not evidence-based, but I think still clinical, extremely relevant to improve continuum of care and avoid readmissions. And of course, there's a small chapter that you will like to look in terms of management end-stage patients, very old patients, patients in whom end of life should be considered. This actually needs active decision in clinical practice, and that cannot be forgotten. And finally, palliative care. There's some recommendations there that you would like to take a look at. So, I mean, being Christian is difficult because we have 10 commandments. Actually, you see here, it is not that there's 16 commandments in these guidelines. This is chapter 16. In fact, there's like 30-something commandments of things that we should do and we shouldn't do. Well, technically, all of us, we should know it by heart, but I would have to say that in clinical practice, in particular in heart failure, this is a small proportion of patients. These are the black and white patients. In the middle, there's a huge proportion of patients. So remember, guidelines do not, never replace a clinical judgment and common sense. Thank you very much for your attention.
Thank you very much. Let's move on to the next and last talk, where Dr. San Roman is going to present the point of view of the Spanish Society of Cardiology about the European guidelines. As you know, the Spanish Society of Cardiology usually endorses all guidelines from the European Society of Cardiology, but also publish a paper making some comments about aspects more relevant for Spain. And we ask Dr. San Roman to present this data here.
Well, first of all, I want to thank the Spanish Society of Cardiology for giving me the opportunity to be up here. To be honest, I have to confess that this is the most difficult and challenging topic I've ever had to prepare, because I've been told just 1 hour ago that I should give it in English, and I had it prepared in Spanish. Anyway, I'll do my best, and I beg your pardon for all the mistakes I'm going to make, for sure. I ask you to be sensitive and generous with me.
You can do it in Spanish, because Pepe Zamorano and Jerome, we did this because Jerome
it's fine. It
doesn't understand, so
it's fine with me. No problem.
It's up to you. You can switch from Spanish to English.
Thank you very much. Anyway. Well, when we read the European guidelines, any European guideline, in the first pages, we can read the following. Clinical practice guidelines evaluate and summarize all relevant evidence available about a particular topic with the aim at helping physicians to choose the best strategy for the treatment of an individual patient with a specific disease, having into account the impact that is going to have in the clinical result and the relationship between risk and benefits of a particular diagnosis and a therapeutic approach. But which is more important to me the guidelines say that the recommendations should help the clinician to take decisions in his daily practice. However, the final decision about an individual patient has to be taken by the physician, which means that the clinical judgment cannot be replaced by the guidelines. So, are guidelines necessary? Of course, there is no question about this. There has been an exponential increase in the scientific literature in the last years. It is absolutely impossible to assimilate, to know, to be aware of every available evidence. And at the same time, there are many different levels of evidence. And the conclusions are different and even contradictory for the same questions. On the other hand, we have to treat our patients with high quality, which means that we have to use all the evidence available. And we have to avoid the variability of the clinical practice. So we need protocols and we need our European guidelines. But the guidelines have important limitations. First of all, medicine is no more, no less than the management of uncertainty. And the decision-making process is based on probabilities, not on certainty. But the recommendations of the guidelines are thought by us as based on evidence, when in most of the times the guidelines are based on the opinion of experts. And experts have their own bias, conscious and unconscious bias. And the guidelines are based on unanimity, but unanimity is not a component of science. Science is made when one is right, but not when many get an agreement, because science is not democratic. And at the same time, we have to take into account, we have to put in perspective the guidelines to our local necessities and our local environment. So as you may be aware, the Spanish Society of Cardiology published its own guidelines until 2000. In that year, the Spanish Society of Cardiology published 33 guidelines, 6 recommendations, with more than 222 authors. And it very welcomed by our cardiology community. In 2011, 9 of the 10 papers more consulted in the European Society, in our journal were guidelines, and 6 of them were Spanish guidelines. But from that year, the European Society of Cardiology published its own guidelines. And our society is a member of the European Society of Cardiology. And the effort was huge when we decided to make our own guidelines. So, since 2003, the European Society of Cardiology guidelines are endorsed and supported by the Spanish Society of Cardiology. In 2011, there was a paper came out in our journal talking about the limitation of the guidelines and suggesting us to create our own committee on clinical practice guidelines. And the aim of this committee is to evaluate, to assess the current policy of the Spanish Society of Cardiology in relation to regarding the European guidelines and to propose the possible changes in our relationship with them. In that paper, the committee had to make the following points. First, the European Society of Cardiology guidelines have to be given out to all the Spanish cardiologists. So these guidelines are translated and published in our journal. And we had to elaborate specific documents about the assessment of the European guidelines. We have to follow any European guideline. We have to promote Spanish experts for the elaboration of the guidelines in the European Society of Cardiology, and we had to propose specific guidelines for topics not considered by the European Society of Cardiology guidelines. I'm going to focus on the second point, the most important, probably the most important point, the elaboration of own documents about the European guidelines. In these documents, we have an introduction about the objective, about the purpose of the document, the nature and the opportunity of the European guideline, a comment on the methodology, about the main changes, the most positive and conflictive points or issues of the guidelines, and the implications of the guidelines for our practice in our country. Of course, when we talk about conflictive aspects, we are not talking about contradicting the guidelines because as I said before, we support the guidelines. I want you to know, to be aware of the methodology of the elaboration of these documents. First, we identify the guidelines which will be published in the next year. Then we choose the coordinators of the comment, one member of our committee and one well-known expert of our Spanish Society of Cardiology. We make up the group of experts responsible to elaborate a draft. We make up the group of reviewers. All of them are come from the sections of the Spanish Society of Cardiology involved in the guideline. We elaborate an initial document, a draft, another draft. We re-elaborate a document taking into account the comments from the reviewers. We re-elaborate the document all together, and finally we have a final document. And it is important, I want to underline this, because these documents are reviewed and approved by more than 25 experts, coming from our Committee of Clinical Practice Guidelines, well-known experts and reviewers from different sections. Are these documents for interest to our cardiologists? Well, I would say yes. These are the accesses on internet for the last 5 documents published in the previous year. Some of them already have more than 10,000 accesses on internet. These are older comments from older European guidelines, some of them with more than 30,000 accesses. We don't want to be referred by other papers. The point is not to make our curriculum vitae. The point is to be useful for our cardiologists. And overall, we have published 23 documents with almost 300,000 accesses on internet. Many people tell me about which is most interesting of the documents. These tables are very well welcome by our community, tables in which we summarize the most important changes regarding the previous guidelines. Tables with positive, with new changes, with conflictive points, with points to be settled, still to be settled. Tables which summarize difficult aspects, like this one, the indication of a defibrillator. Like this one, with different evidence or type of recommendation to different drugs in before non-cardiac surgery. Or this table with signs and symptoms specific for the diagnosis of hypertrophic cardiomyopathy. Or this in the right about the number needed to treat to avoid sudden cardiac death. These are the documents elaborated by our committee in 2016. Heart failure, cardiovascular prevention, dyslipemias, and atrial fibrillation. And our comments were presented yesterday in Auditorium 1. It was, I have to say that it was quite crowded, like this one, like this today, which means that our cardiologists want these comments. And I want to finish, to conclude, I would say that, of course, there is no question that our Spanish Society of Cardiology support the European guidelines, but we elaborate own documents assessing these guidelines. These comments summarize the changes, the limitations, and put in perspective, in local perspective, the recommendations of the European guidelines. The documents come out thanks to the hard work of many members of our Spanish Society of Cardiology, and these documents are very well welcomed by our community. Of course, I want to thank all the current and previous members of this committee. Nothing would be as it is without them. So thank you very much, and thank you very much for your attention.
Okay, I think we have some time left, so we can take some questions. Can you come here? There is any question from the audience?
If not immediately a question from the audience, then let me ask to Hector Bueno. Hector, you were part of the heart failure guideline writing committee. If I look at this heart failure guideline, it has become very complex here and there. In the daily practice, specifically the diagnosis of heart failure with preserved ejection fraction, how do you deal with that in your daily practice? Is it something that you specifically diagnose, or is it a diagnosis that when you exclude everything else? How do you work with that? Because it's very complex. When you see your patients on a daily basis, when they get older than, let's say, 65, everybody complains of tiredness and dyspnea. So they will all have an ejection fraction that's relatively preserved most of the time. So how do you deal with that?
Well, I don't think I have a clear answer for that. The problem is, as you say, that these are usually older patients, usually not pure heart failure. Some of them are anemic, most of them are hypertensive, a lot of them have some hypertrophy. So, of course, you have preserved the ventricular ejection fraction measured usually by the Simpsonics. Actually, you have some techniques, you may find some difference if you use a strain or some other techniques. I think if you have high enough levels of natriuretic peptides, that's useful, but still I would say that the majority of these patients are the community. For instance, in Spain, there's many primary care doctors that do not have access to natriuretic peptides, so become very challenging, because if we were referred to all these patients for echo, for cardiac evaluation, it would be probably overcrowded. So in my recommendation, it would be to be more flexible in the use of natriuretic peptides in different levels, because I think it would unload the number of echoes that sometimes are requested from older patients, sometimes very fat or with COPD, anemia, and so on. And I think we do a lot of echoes, for instance, with that. In terms of management, again, I think I agree that you have to have common sense. If there's clear evidence of volume overload, diuretics is an obvious treatment, and then management of hypertension, which I would say 75–80% of patients have. But there, again, we don't have really good evidence for anything else. So in general, I would say, and that's why I emphasized taking care of comorbidities and a global view of these patients is absolutely essential. I think the narrow focus on heart failure many times, and most times in particular in these patients, is just too narrow.
Yeah, and I think I agree with you that if you look at the typical heart failure patient, they are not presenting like most of the atrial fibrillation patients. Most of the atrial fibrillation patients, they don't have much else but just atrial fibrillation, whereas the heart failure is very complex. And I think one also has to be careful that we do not make the mistake that we start to put everything in guidelines. A lot of things are also common clinical judgment, and so you have some basics that you check according to guidelines. You have also basics in therapy that you do according to guidelines. But if you start to try to catch everything in one guideline, it becomes almost impossible to adhere to that. I also had a question to Paulus. Paulus, what in your atrial fibrillation experience at the moment is in the UK the percentage of patients coming with new atrial fibrillation that get a NOAC as compared to warfarin?
Now, that is actually in the UK that has changed a lot in the last 18 months, and that is partially because NICE, our health economics agency in the UK, has basically stated that NOACs are actually cost effective in their current pricing. There are some areas in the UK where there are very well established anticoagulant services, and they will probably still offer vitamin K antagonists to patients with newly diagnosed AF as the first line, but more and more hospitals are moving to prescribing NOACs as the first line therapy. So that I would think it's probably about half-half, but we are really seeing market change. So 2 years ago it was a minority of patients who were treated with a NOAC when they were first diagnosed, and only after justification, a trial of vitamin K antagonists, they were offered a NOAC. But now, for example, in our hospital, even the non-specialist acute physicians regularly prescribe NOACs, and we see increasingly in our specialist atrial fibrillation service that patients come, and it's almost the norm that they have been prescribed a NOAC before they actually come to the AF service, whilst 2 years ago we were typically the point of care that started the anticoagulation.
What is this situation in Spain? How much of the first comers do get NOACs as compared to warfarin?
I don't know exactly about first comers. In general, we have significant heterogeneity between regions. You know, we have 17 different regions. I would say that on average there is about 30-35% of patients that get NOACs, but we go from 17 in some areas to maybe 50 in others. We are improving. And probably in relationship with the new guidelines, we are going to see in the near future also a change, since now there is a recommendation of giving NOACs to the first diagnosed patient with atrial fibrillation. But the situation now is this: we have to deal with 17 authorities. We don't have the NICE here that give that this is, and the Spanish Society of Cardiology have to fight with the Ministry of Health in trying to improve these differences.
Yeah, there's actually regions where we're not allowed to prescribe NOACs as a first line. You have to wait, and if the patients do not tolerate, cannot be controlled, have bleeding or have allergy, then you're allowed to. But as a first choice, there's regions in Spain, and the problem is we don't have a healthcare system, one healthcare system anymore. We have 17, and there's no necessarily alignment between recommendations are different, which is a real shame, I think. For
there are clear indications coming from the Spanish Society of Cardiology about this, but we cannot follow them depending on the community or the region we are working.
So this makes what you presented actually even more complex in view if you want to translate guidelines into your national situations.
Absolutely right.
I think also when you discussed very elegantly about implementation, in this case in Spain, but I think every country has its specific issues and problems. I've been traveling a lot over the past so many years to different countries, and specifically if you compare Western Europe with Eastern Europe, then you start to see the real differences, where there is countries where there is absolutely no money for almost everything, and then you start to see we can draft these guidelines and issue that, because based on the literature that's probably the best way to do, but the practicality is often quite different. And I think this is also something that with the development in the relation between industry and physicians and other things related to that, economic circumstances, I anticipate a further widening between Western Europe and Eastern Europe. But when you listen, for example, when I visited, I think it was Bulgaria, and you ask or I was told without asking, what an average cardiologist, one in the age range of, let's say, 50 years old, fully specified, specialized, everything according to the rules. A person like that makes about 800 euros a month. So then you start to see immediately these huge differences that we have within Europe. And I think that that is one of the biggest drivers for lack of implementation that we can do in Europe.
I would like to ask Alberto, because I think it is an opportunity for some of the people who are really involved in guidelines development from Europe, because you have shown very nicely how rigorous the evaluation here in Spain about the ESC guidelines. Do you have any general view of how the European guidelines are perceived by general cardiologists, for instance, here in Spain? Or do you see any heterogeneity between different guidelines, European guidelines, in terms that there's very difference? You have a general view of the European guidelines, or do you think each guideline is very different?
Well, it's just my opinion. I think that in our community, most of the cardiologists look at the European guidelines as the Bible, which means that everything should be done as God.
And they are believers.
Everything should be done as guidelines show us. And they don't look at the guidelines as a tool to improve their management of the patients. It is a tool that helps you, but you cannot look at the guidelines as they are the law. I know if I make myself clear enough. So I think the change has to be done to have the guidelines with you. They are very, very, very helpful. Not as the most evidence-based point, but as the most useful when you have a patient facing you. So this is the point to me.
I think that's a very good point that you make. Guidelines, and that's where we start with this sentence in the beginning, they are helpful for us if we manage on a daily basis the patients. The big algorithms, everybody knows what to do when we have this or that. Sometimes you get a bit stuck, and then you can look in guidelines, what do they prescribe? Sometimes, based on new evidence, things are changing recommendations, and that is when it's useful. But I think before anything else, one should always realize that these are guidelines, and nothing more, nothing less. And that means when you see the patient and you feel that in this patient you don't want to adhere to this because of so and so, that is what matters. And I think in the US, guidelines are using more and more in court against a physician who's treating a patient. I think this is some direction which we should absolutely not go. We should absolutely not go there. This should be helpful to manage our patients, but it should not be something that you can take to court and then start to discuss based on that. So I fully understand what you just said.
In fact, I think that we are not being good at letting know our fellows that clinical judgment cannot be replaced by anything. Our fellows follow the guidelines strictly. They have a track and nothing outside the track.
That again is something we discussed yesterday when I did the presentation at the general opening, that there is also a change in way of treating patients, and I would describe that a little bit as a generation gap, because you say, and you've probably been trained, like most of us been trained, so many hours in the hospital, seeing so many patients. But now the teaching and the practicing is changing a little bit. You see a patient, you take then the guidelines, say, okay, I have to do this algorithm, you put the algorithm. But that is not what we are eventually trained for. Eventually we're trained for to treat these patients, and over the years you get your experience, but guidelines are just there for us to help us in decision making when we get a bit stuck. But that thing is not new, what I just described, because I trained in the United States in 1990, and already then I saw that over there they were much ahead of us by using algorithms. So many of them, I was just in the beginning of my career and I was doing the rounds, and many of the assistants that were going with the professor asked some questions, and the only answers they gave, because we saw a guy who was yellow and he asked some questions about pathophysiology, and they could immediately say, well, the bilirubin has to be so much higher, otherwise you don't get this. But the real question is, of course, what's your differential diagnosis? If you look, for example, at the triple rule-out CT in the emergency room, that is a CT scan where you exclude coronary artery disease, pulmonary embolism, and aortic dissection. But if you see these patients in your emergency room, when is your differential diagnosis like that? Never. So I think that we should therefore try to keep in Europe what we have, is that we learn good clinical management, and you teach that to the people that you teach to. And based on that, these guidelines are there to help us. But that really is where I think we should go, and we should not move away by doing, because that you see also, and I don't know how that is here, but in Holland you see this development into nurse practitioners who take over a lot of the work from the physicians. But when you see those patients, for example, when the cardiothoracic surgery has been done, there's a nurse practitioner and rounds on the wards, and then she discharges the patient, and then all the algorithms are being applied. But often it results in that this or that is given to the patients, whereas there is actually a clinical contraindication to not give it. Or to give it. And I think that makes the difference of good thinking and just looking at the patient and just not blindly applying algorithms. So I think if I would have given your talk, I would have only focused on that, because guidelines are good and we need it, but we should not completely overdo it. Yeah, sorry, we are exactly on time now, so I think we can stop. I want to thank the last of you for your attention. It was a pleasure to be here. Thank you very much. Thank you to the speakers who did a wonderful job.